Hi, everyone, and welcome to Overfilled, the podcast. I'm Dr. Jamie Kuzner, and I'm here joined by my besties in the optometry world here, Brooke Messer and Jason Jedlicka. So, Overfilled, the podcast, we're here to talk about awesome cases, experiences that overfill us in our life, both professionally and in our personal lives with our families. So, we have a really interesting case that got submitted that we're going to talk about today. But first, who wants to kick it off about what overfilled you this past week? Do you want to go first, Jason?
I can go first. So this weekend, I got to hang out at your alma mater, Michigan College of Optometry, for the AOCLE meeting. Always a good time to see other contact lens educators and get a little bit smarter and stuff. Our topic this time was about pediatrics, which I'm not all that excited about, but again, it was good to see friends and colleagues that I haven't seen in a while. So enjoy that meeting. And then, of course, last night, just to tip off to maybe what Brooke's going to talk about, to get to have someone special do the ICKC event at IU last night was another overfilling time.
What was a cool pearl? Did you have any cool pearls from the pediatrics that you want to share? Anything that you learned?
Well, I mean, so there was some cool stuff. Yes, we had a lot of pediatric disease management lectures. We had a lab where we didn't all do it, of course, because the little kids wouldn't have liked it. But some people put contact lenses into like 2-year-olds' eyeballs, and they practiced how to restrain them and all that for that business. That was kind of fun.
Oh, poor kids.
But yeah, and then we had some demo of some instrumentation up there that does again like really big OCT images, which was pretty cool. So Josh Latosky and Chad Rosen, those guys up there, showed us some of their fun toys. So it's good. It was good. Yeah, and then there was another lecture again about spectacles for myopia management, which we don't have, but you Canadian listeners have. And we hope to have soon. So that was fun. Yeah.
Yeah, you kind of have to stay up to speed so that as soon as the spectacles are ready, we can prescribe them with confidence. So I'm always interested in hearing about them for myopia control. And I had a 1-year-old a couple of weeks ago that has myopia and kind of co-managed with one of our pediatric specialists here in town to try and decide what to do. But those are always some tough cases. So like you said, it's something that the three of us maybe don't encounter quite as much, that real like small pediatric, but still got to know it on the occasions that they do present.
You're not that far from Canada though. Can you send prescriptions and patients to drive a few hours north and get spectacle?
So we have 2 providers that are close enough that if patients decide that that's what's best for them, I usually just refer them and then let them kind of handle everything versus me just sending a prescription. And then we just help with the axial length checks routinely. Cool. So we have had a couple patients go up there, but I wouldn't say that I've seen the patients for follow-up because we just don't really do the glasses follow-up. So, but that's still all been within the last few months. So I wouldn't say I'm more than 6 months in with some of those patients.
Okay.
So still looking to see how it goes.
But I should look into doing that because I'm so close to the border too. I have patients that are high prescription and they go to Canada because they can do apparently they can do a higher index than a 174, or I think it's because they don't have the St. Nancy standard, so they can make them thinner.
Yep.
So I do not advise them to go over there because of that, but they will. So I have some patients that go on their own because they can make them thinner. I don't know if they are safe, impact resistant safe. Makes me a little nervous with how thin the central point can get, but I should look into that.
Yeah.
Very good.
Yeah. It's really for those patients that just are definitely not candidates for a myopia control contact lens. And for whatever reason, we decide atropine is not strong enough or whatever it is. So, but it, it fits for some patients, but thankfully I can do most of them here with a contact lens of some kind. Yeah. My overfilled moment, thanks for the spoiler, Jason, I got to do the ICKC program for IU last night. We do that virtually most of the time. I've been to 1 or 2 schools to do it. And I feel really fortunate to have been, connected and asked by Glaukos to be part of their speaking team. So ICKC stands for the Continuum of Keratoconus Care, and we talk to second and third year optometry students about, detecting keratoconus, being more confident, talking to their patients about it, understanding corneal cross-linking a little bit better. And then we also talk a little bit about other surgical managements for keratoconus. And I feel like every time I give the program, I have a little bit more to add now that we've been doing a little bit more on the surgical side, even beyond cross-linking. And being part of some of the other trials, like here at the clinic, we're part of Glaukos's Epion clinical trial too. So it's kind of neat to be able to bring, kind of the full spectrum of what Glaukos is trying to do. And I really enjoyed it last night. That was good. And the students had a lot of good questions. Many times when you give a lecture virtually, from 7 to 9 p.m. their time, they just want to be done at 8:50, and there's not a lot of questions, but there was probably 5 or 6 questions from the students that were insightful, asking about cross-linking or, why or who. And so I thought that was really good. And, the team that puts on the ICKC program, led by Dr. Clark Chang, who's a great friend of ours, just wonderful person in the industry. But, Ursula is behind it all. It's kind of like the staple program for keratoconus, really. And so it's always good to connect with her and her team too. So Jill was on the call last night as well and was very happy to be there.
I love that. I wish that they had that program even for current doctors that are out practicing, because I think there's a lot of misconceptions about cross-linking and when to refer them, or it's very interesting when you go out and talk to a lot of doctors that have been graduated for quite a while. They just didn't learn about it in school. And maybe they don't go to a CE about cross-linking, so they don't really know. So that's a great program. I'm happy all the students are coming out with such good knowledge nowadays.
So heads up to Clark, put it together for practitioners. As I was listening to you go through that last night, Brooke, I was thinking, this is some of this stuff is pretty advanced, and I hope my students are getting it. But I don't think it's even too basic, again, for practitioners who are in practice. I think the program, even as it is, could be done. Maybe they need to, maybe they do, maybe they have this in a webinar form for practitioners and we don't even know it, but it would be a good idea if they don't.
Clark and I had dinner together 3 years ago at GSLS, and we came up with this lecture called The 10 Things You Don't Know About Keratoconus. And I gave it at GSLS the following year as a breakout one. And it has a lot of that similar aspect where it's you don't have to have a thin cornea to have keratoconus. You don't have to have a steep cornea to have keratoconus. Single point pachymetry. I think, Jamie, you were at the lecture.
It was a really good lecture. It was really good.
So it has it's a little bit more practitioner faced on hey, here's the testing you do in your office, and then here's how you might miss keratoconus. So, this is what you would be looking for. But I agree. And there's a few things, and Clark is always throwing ideas around. I'm you should do this lecture. You should do that lecture. And I'm why don't you do it? Or let's do it together. But, and of course Jason and I are lecturing with him at Academy this year on keratoconus controversies. So that might bring some of the spirit of ICKC to a practitioner education. But, the energy that Clark brings to managing keratoconus is just so good, and keeps it fresh, or tries to keep it fresh so that it's applicable to practitioners of all management levels. Because I think, people like us, where we see a lot of these patients and they're doing great in their contacts, you could get complacent with well, they're seeing great, and then you just let them go, versus making sure you're getting those pentacams and monitoring the cornea. So it's just a good reminder that we can't get, distracted and think that they're doing fine just because they have a really good contact lens. So patient advocating here. Clark Chang, go Glaukos. Yeah, love it. He would be a good special guest sometime. So, what's your overfill, Jamie?
Yep, back to you.
Back to me. So my oldest baby, Olivia, so she's 5.5. I alluded to this last episode. She graduated from her Premier Academy, which is where she went to daycare and preschool and young fives. So I had her graduation, and I have a little video of it. So they got to go up to the microphone and say what they wanted to be when they grow up. So I'm gonna have Jason show the video for us.
Olivia! I want to be a singer and an eye doctor.
Yeah. So
Taylor
So
Swift
good.
only. Is that what she wants to be?
specifically Taylor Swift, and an eye doctor, because I did tell her that Taylor Swift and I are the same age, and she made the connection that when I'm ready to retire from being an eye doctor, that Taylor Swift will probably be ready to retire from the Eras tour. So she said, "I'm gonna someone." She goes, "Well, someone will have to take over her tour, so that will be me." And also, your practice. Like she walks into my practice all the time and just says, I'm going to run this place. Like I'm going to take over.
Yeah.
And it was very cute too that there was 2 other of her classmates said they wanted to be eye doctors also.
Wow.
Actually, they both said they wanted to be eye doctor teachers specifically, because we've had that conversation that every time I fly to lecture somewhere that I'm being an eye doctor teacher, and you can be both. And so Olivia must have told her friends, and they all thought that's really cool to be a teacher eye doctor. So
Yeah.
Look
we got future
generation.
I know, it's just precious, and I was like crying, and then my 3-year-old was like looking at me like, "Why are you crying?" And then like every time something happens, she goes, "Are you gonna cry again?" I'm like, "Probably." Like probably.
I think for those of you who
But
don't know Jamie, she is a bit of a softie. I've seen many a happy tear come from your.
Yeah. I know, but it was so good. But she's been at that school for 4 years, so I mean, it's kind of all she knows. So it was really cool. She's growing up, but also I'm very proud that her and her friends all want to be eye doctors. And apparently I'll take over Elevate Eye Care apparently.
Well, by the time they get to that point, you'll have 2 other
Right.
docs with you, so they'll need
Yep.
3 to take over.
Yeah.
Just like move right in. So
Yeah.
that was my Overfilled. And then of course, I mean, I had some really cool patients that I saw this week as well. They did a lot of new fits. So I can't wait to do their dispenses in the next couple weeks to see how they did with their lenses. One of my patients hugged me just after the after the trial fitting, that she was like so excited to wear a contact again that she hugged me. I just met her for the first time. So I'm anxious to get her lens in and see how she does with it when she takes it for a test drive. So
Yeah.
very cool stuff, like always.
Like always.
Ready for the big hug.
Like always. I've never hugged one of my doctors, but apparently all of my patients want to hug me, which is
It's that softy in you.
it's just, that's what it is, right?
Yeah.
Very cool. So we have a really cool case submission that got submitted to us. So we will jump into our case. So we have a couple video files that I'm going to share and a couple pictures. So I will try to do your case justice. But we had this submitted by Dr. Noah Safe. I believe I'm pronouncing your last name correctly. So she's really cool. You guys should follow her on Instagram if you don't follow her page. She posts a lot of really cool fits. So she has a specialty contact lens practice out in Seattle, correct?
Yep.
I believe it's out in Seattle. Okay. So just to kind of give you a summary of what her case is, and then I will share the video. So she had a patient that was referred to her from a practitioner because the lens was decentering and had excessive volt with a traditional scleral lens. So the patient was an aphakic. Oh, I think I cut that part out here. Hold on. Let's see. She is an aphakic corneal transplant cornea plana patient with an ectopic pupil. Wow, that is like so much going on, right? So I'm going to share the video of what the current lens looked like here, and you guys can tell me what you think. This is the previous fit, so not her fit. So there's the lens on the eye.
Oh, I can't see it on mine. Oh, there it is.
There it is. So that was her current lens that came in as a referral.
Yeah.
So obviously extremely, extremely decentered. So you can see how the superior.
Not terrible in terms of like if that's the best you could do, but I think you could tell the optic zone was way down and her pupil was way up. And so I think if her pupil had been in the middle, maybe they could have gotten by. But clearly in this case, that decentration with the superior decentration of her pupil really meant a big mismatch in the optics of the lens.
Right. And then if you go to the PowerPoint where I put some of her pictures, Jason, so there's a picture of her eye. So as you can see, her pupil was obviously very displaced superiorly, which is opposite of what the lens is doing, which is excessively inferior. And she also has a high plus because she's an aphakic. So there was that mismatch between the optical zone and her line of vision. So her goal was just to get the patient to see the best that they could. They wanted the best vision possible. So she wanted to be able to change the optic zone, will also prevent the lens from decentering. If you go to, let me see the next slide.
Mm-hmm.
So she did do an eaglet on this patient. And I have the same issue too, where sometimes with the cornea and everything is so distorted, you can see how irregular it is, but the profilometry scan wasn't even able to like detect where her cornea was. So it does make things a little tricky when you're trying to use these higher level technology devices. So there was her eaglet scans.
We'll go back to that one. I think look at the curve down below. Look at the profile of her cornea. Look how flat it is.
Yeah.
There's no delineation between the curvature of the cornea compared to the sclera there, like there is in everybody else's eyes. So
right.
I think it had a difficult time picking up the cornea because the cornea and the sclera are really just continuous in terms of their shape. There's no demarcation where you see a change from cornea curvature to scleral curvature.
Yeah, I had a patient with cornea plana recently as well. And I did an eye print, and then I sent the mold, and they basically wrote back and was like, I don't see anything on this mold.
Yeah.
And
right.
I have an OCT as well of a lens. Like, it's just so different. And we ended up doing like an oblong ovate lens that's long this way to try and like kind of use the lids to try and center the optic. But I'm excited to see where this one goes here.
So she decided to do a freeform lens to let her go as flat as she could. And then she also did a larger diameter to help lift up the lens. And then she did something really interesting with the multifocal too, which this is just an image of her freeform lens. Let me see. I'm going to share.
Yeah, I think one of her talking points was that when she tried to make a lens for this patient with the full prescription, which is like plus 30, in the optic zone of her lens, she wanted to decenter it to get it over the patient's pupil. But because of the nature of the lens, it created an area on the lens so thin at the inferior border of the optic zone that the lens would break. It was fragile. So because it was such a high prescription, decentering the optic zone in this case just didn't work. It was such a high RX and such a high plus RX, it didn't work. So that's why you're saying she had to get creative. So
exactly. So can you guys see the other screen that I'm sharing right now?
Not yet. Here we go. Oh,
there we go.
Not that one. Try it again. There we go.
There we go. So there's her freeform lens, right? And so, like you said, the base curve was a 12 diopters, like so crazy, right?
Yeah.
19 millimeter diameter lens with a multifocal with the add power of a plus 20. Yes, because like Jason was saying, that the lens juncture was too thin to manufacture. So she ended up doing that center distance multifocal to get the add power into the periphery of the lens. So she ended up ordering it as a plus 12 88 with a plus 20 add power with a decentered optic.
Yeah, and the lens doesn't look all that wacky. I mean, the patient's eye isn't horribly distorted, but again, to have the ability to create that add power like that plus 20 add power and decenter it like that is really very, we're really talking about high level customization there in this case, which is really cool.
Yeah. So before the call, Jason and I were like, wow, a plus 20 add power, but like amazing. Like I would have never even thought to do that.
Correct.
Very creative. So creative. And then she said that remarkably the lens, she could see 20/40 vision. And then her next step would be to add is actually HOA optics with the OVITs to make it even better.
Wow.
So look at that. So that's a very, very special lens. So it said the Ovid's team already knows that to do the decentration superiorly. But very, very cool case. Love the submission. Any other thoughts that you have about this case?
My thought is, when we look at these decentered optics, sometimes you can do like a topography and then use a caliper to find out like exactly where their line of sight is, because obviously she's got this nailed and knows what she's doing, obviously. But if you're attempting your first decentered optic, just because they have a superior pupil doesn't mean that's where they're looking. Like this patient's line of sight might be right at the border of that inferior iris. So you want to take some sort of image where you can have them look at the light and then see that image in the reflection of the instrumentation, and then map that according to known landmarks, whether it's like the limbus or the center of the cornea, and then you can, or even the center of the lens if you put the lens on, because then you can look and see with your maps the center of the lens and then where their actual line of sight is, and then you can communicate kind of that angle and amount of offset from the optics of the contact lens. So that's where you can go when you're looking to do something like this. You don't necessarily try and put the center of the optic at the center of where their pupil is, because that's not necessarily where they're using their pupil.
Yeah, I would just say how remarkable it is, just going back a few weeks ago when I got to give the keynote at ICSC, and we talked about the history of sclerals just since I started practicing a while ago. I mean, they didn't even, you couldn't even prescribe them 25 years ago, really, right? And then they came out to like the public, so to speak, where anyone could get a fitting set and start fitting them in probably like 03 maybe. And so that's 20 years ago. 20 years ago, we had spherical base curve, spherical everything, you couldn't customize anything. Couldn't really even put toric on it or anything. And now just 20 years, we are making these incredibly complex shaped lenses with HOA optics, with multifocal optics, with decentered optics. I mean, think about the evolution of any other type of lens in a 20-year period. It's nothing like this.
Yeah.
This is just the coolest thing for us to get to live through, because for me, at least, I when I started practicing, this didn't even exist at all. And for Brooke, it was really just the beginnings of it. So sclerals were around, but again, they were really basic sclerals. And Jamie's been around a little less, but still, I mean, what was even there 7-8 years ago compared to now? Yeah. And so to get to be practicing in a time when this is happening before our very eyes is just really cool. There are patients who 20 years ago, we couldn't have fit them in a lens. Or if we could have, it would have been a horribly fitting, mediocre vision lens. And now that same patient can have a really well-fitted, comfortable lens and maybe 2020, 2015 vision with HOAs. It's pretty crazy. So I love this case because it kind of pulls out everything about what's new and exciting about sclerals, from the customization of the design to the decentered optics to the multifocal to the HOA. So thank you to Dr. Safe for sending this. This is exactly what we beg for every week, cases like this. Something interesting. It's really fun to walk through this one.
Yeah, and if you want to submit a case, it certainly does not have to be this complicated. She is obviously very excellent in what she does, and it's just fun to highlight the technology and everything that we can do. But we're also wanting to see cases that are troubling you, just like the one we tackled last week.
Which was a great case to talk through.
We had so many great talking points. And so again, don't feel like a simple case is not good enough or your case isn't advanced. Because we hope that there are listeners kind of all skill level, and that kind of anybody can take away something from every discussion. Because again, like I don't even know where I would have gone had this patient been in my chair. And
well, you know what's interesting in this case too, I think another approach that someone could take in theory, and just to go off on a tangent, because like Dr. Safe had mentioned, that a lot of people would question whether it was wise to put an aphakic corneal graft in a scleral this thick, and so what else could you do? I think if I didn't have her level of creativity with this one, I might have even just ordered a custom soft lens,
and just go
like a large, like 17, 18 millimeter diameter soft lens with a good bit of power in the soft lens, so that it created a little steep spot in the middle of the contact, and then fit a GP over the top of that, like piggybacking it. Would have been another way to do it, because the soft lens in theory might have centered a little better, but again, you're still not really decentering the optic quite to the extent that she was doing, where I think, again, this is a better approach. But
and
the custom.
Oh, go ahead.
I was gonna say, in the custom soft lens too would be really thick. So how much better is the DK at that point? I mean,
you don't gain anything there at all either. It's just, again, it's just another way you could probably have done it, maybe 10 years ago. I can remember doing something like that way back in my residency, before scleral lenses were even around, where we had somebody with a really high plus power and a really flat cornea. And that was one thing that we actually tried, was putting him in like a plus 15 soft lens and then fitting a GP over the top for the rest of it. And it worked, but it, again, not very breathable and not the best solution. So
yeah, being in a surgical practice, I'd have to review Peter's anomaly and if there's contraindications to this, but I would wonder about like a sclerally fixated IOL or even an artificial iris to recreate that pupil and center it up, and try and change the power of the eye a little bit to get into a more, normal powered scleral lens. With the cornea plana, that may be a challenge from an eye shape. Like it might just be too small overall to get a lens inside the eye. But that was one of my thoughts.
IOLs are pretty skinny.
They are.
But you're still
more like,
even with an IOL, you may still end up with a good bit of prescription left, because it would probably take about a plus 35 or 40 IOL to create correction at the plus 33 level, and I don't even know if they make that. And I wouldn't piggyback an IOL in an eye like that either, because of
no, definitely not. But the just some other thoughts on and it's kind of interesting, having been in a contact lens practice and then now being in a surgical practice, like how you kind of think about those things. But sometimes these eyes have already had enough, like it's been through a cornea transplant, and like piercing something through the sclera is just not a good idea at this point, especially with the transplant. You don't want to stir up any inflammation or anything. So
and an anterior chamber or fixed IOL would probably age the graft a bit too.
But anyway,
great case.
Super good case.
Congratulations on finding a solution for this patient.
Yeah, and we will definitely watch her grow her 15 minutes of fame into something more, I would anticipate. So
for sure. And she also had some for our call to action about ICSE and suggestions for next time, Brooke. So I'm giving them to you. She does love the idea of the 15-minute rapid fire cases, which we did for residents. A lot of good feedback on that. And then like a talking point on discussions of controversial or debate between, fitting, like this case, a debate between doctors of why would you fit a gas perm versus a scleral lens. Yeah. And then also maybe a lecture that looks at a deep dive into fitting sclerals around blebs.
Sure.
I think that's a really good talking point too.
Sure.
Yeah, because there's so many different ways you can these days, between notching and vaulting and free-forming it. It would be fun to have a panel where people brought even just 10 minutes per person, talked about how they work with blebs.
Yeah.
That would be a really cool topic.
There's so many good ones out there that do. So
yeah.
Super. Well, thanks for the discussion, you guys. Happy Wednesday. And
you too.
Look forward to seeing the cases roll through. You can find us on Instagram at Overfilled_the podcast.
Oops,
you can find us.
On.
All right. You can Overfilled the podcast at gmail.com.
For those who are watching, we have to get the visual in.
Yep. Overfilled_the podcast. And the other thing we want to see, maybe through social media, is we want some suggestions on who you want to hear from. So let's find out who our next featured special guest should be, because we want to talk to him.
Yeah, we already had Bill Shelley. Hard to beat Bill, but we'd
Mhm.
love to have another special guest at some point.
Yeah.
And so if you have ideas, let us know, because we may be able to coax them to spend a half hour with us.
There you go. Just send us a DM or a comment. You don't need to know them personally. Maybe you're like a fangirl of them and you love them and secretly, and you've never met them. So just let us know and we can make it happen.
Yeah.
We'll make it happen.
And send us
So-
cases, because we are fresh out of cases to discuss, and we have another show in a week. So we need a case before next week. Come on, everybody.
All right.
Maybe we can get Lynette Johns on there, because you guys know how much I love
We know
Lynette so much. And I'll post this and really embarrass her.
Yeah. Well, I sat next to Lynette on the bus back from MCO to Grand Rapids on one of the days, and we had a nice discussion about limbo clearance on the bus. So I'm sure we could fill a half hour with controversies.
Nerd alert.
Yeah.
All right. We'll see you guys next week. Thanks for
All
coming.
right.
Everyone.